Our time now in Manila is exactly 12:02 p.m. and I am speaking from the video conferencing room of the UP Manila, Padre Flower Street, Ermita, Manila. Today's topic is management of resistant hypertension, and the objectives of this webinar are the following: to define resistant hypertension, to name the most common contributing factors to resistant hypertension, to be familiar with the basic approach to the pharmacologic therapy of resistant hypertension, and to understand the impact of non-pharmacologic methods of managing resistant hypertension. And today's speaker is Lorraine Banggayan. Dr. Banggayan is a summa cum laude graduate of the BS Biology program from the University of the Philippines in Diliman. She was a consistent scholar, college scholar, and also continued her postgraduate medical education at the UP College of Medicine. She did her residency in internal medicine at the UMass Memorial Medical Center in Worcester, Massachusetts. She did her fellowship in cardiology at the Loyola University Medical Center in Maywood, Illinois, where she was honored as an outstanding cardiology fellow. She also did another fellowship in nuclear cardiology at the Northwestern University Medical Center in Chicago, Illinois. She specializes in adult thoracic echocardiography and cardiology. She was an instructor in clinical medicine at Northwestern University Medical Center, and at present she is the chair of the Division of Cardiology at Oak Forest Health Center in Illinois. May we all call on Dr. Banggayan.
Thank you, Randy. Thank you for the kind introduction. And thank you for this opportunity to share with you my approach to the management of resistant hypertension. First, I'm going to talk about the definition of resistant hypertension. Then I'll be discussing the various factors contributing to resistant hypertension. Then we'll talk about pharmacologic as well as non-pharmacologic therapy of resistant hypertension. Resistant hypertension is defined as blood pressure of greater than or equal to 140/90, despite the patient being on 3 medications of different classes, one of which is a diuretic. And each of these drugs has to be at 50% or more of its maximum recommended dose. There are various factors that contribute to resistant hypertension, and it's important to identify these since reversal of these factors can improve blood pressure control. Some of the more common factors are patient compliance, use of agents that raise the blood pressure, and the possibility of secondary hypertension. Let's first talk about patient compliance. One of the most common reasons for uncontrolled hypertension is failure to take his medications regularly. So it's very important to do medication reconciliation. I have the patients bring their medication bottles with them to my clinic so that I can see exactly what they've been taking. If they don't have their bottles, I try to check their pharmacy refill history using electronic medical records, or I call the pharmacy where they get their medications from. It's not uncommon for me to find medications that have not been refilled for several months without the patient realizing it. And that's because the patients are often very overwhelmed by the sheer number of medications they're on, and it's just hard for them to keep up. So sometimes just refilling the missing medication would be enough to get the blood pressure under control, in which case the patient's hypertension is not necessarily truly resistant, it's just uncontrolled due to poor compliance. Simplification of the dosing regimen can also improve patient compliance. So if there are equivalent drugs that can be dosed once a day instead of 2 or 3 times a day, I would choose the drug that I can dose just once a day to make it easier for the patient. Improving the patient's understanding of hypertension and its consequences also helps to improve patient compliance. I spend some time with the patient to explain to them what hypertension does, because hypertension, the problem with hypertension is that it does its damage silently. So as long as the patient feels well, he doesn't necessarily feel compelled to take his medications regularly. So I have a heart model in my office and a model of an artery that I use to illustrate the consequences of hypertension and how it causes stroke, heart attack, and heart failure. So I find that improving their patients' understanding of the consequences of hypertension motivates them to take their medications more regularly. Another contributing factor to resistant hypertension is the use of agents that raise the blood pressure, most commonly nonsteroidals. I have a lot of patients with chronic pain or chronic recurrent pain for which they take a nonsteroidal every single day, even on days that they're not really hurting. Sometimes they take their nonsteroidals more regularly than they take their blood pressure medications. But the problem with nonsteroidals and COX-2 inhibitors is that they do raise the blood pressure. And it's not uncommon for me to find, it's not uncommon for me to see 5 to 10 millimeter drops in systolic blood pressure just by having the patient stop his nonsteroidal or minimize the use of nonsteroidals. Other common agents that could raise the blood pressure are decongestants and oral contraceptives. In any patient with resistant hypertension, the possibility of secondary hypertension has to be considered. More commonly, renal artery stenosis, primary hyperaldosteronism, and obstructive sleep apnea. I won't have time to discuss each one of these, but suffice it to say that one should have a high index of suspicion for these possible secondary causes of hypertension when faced with a patient with resistant hypertension. Therapy of resistant hypertension begins with a cornerstone 3-drug regimen consisting of an ACE inhibitor or an angiotensin receptor blocker, a long-acting dihydropyridine calcium channel blocker such as amlodipine or nifedipine ER or felodipine, and a diuretic. Unless there are contraindications, I try to switch the patient's, or I try to modify the patient's medication regimen to include these 3 classes of drugs. If the patient is already on these 3 classes of drugs and the blood pressure is still uncontrolled, I take a closer look at what type of diuretic they're on. Diuretics are key in the management of resistant hypertension because of the persistent underlying persistent blood volume expansion despite the absence of edema. Oftentimes when a patient comes to me on a diuretic for hypertension, that diuretic is hydrochlorothiazide. The problem is hydrochlorothiazide is not as effective as chlorthalidone or indapamide in the control of blood pressure, partly because it's shorter acting. So if the patient is on hydrochlorothiazide, I typically switch it to chlorthalidone. Or you can also use indapamide. But if the patient's GFR is less than 30 ml per minute, thiazides become less effective and loop diuretics will be required. You could use furosemide or bumetanide. These are short-acting diuretics though, so they need to be dosed at least twice a day for effective blood pressure control. Torsemide, or I believe in the Philippines this is toracimide, has the advantage of being longer acting and has more consistent absorption, so it could be potentially more effective than furosemide or bumetanide. So if a patient's already on the cornerstone 3-drug regimen and the right type of diuretic and the blood pressure is still uncontrolled, I look to add an aldosterone receptor antagonist, typically spironolactone. And I use eplerenone if the patient is spironolactone intolerant due to gynecomastia or any other side effects. Aldosterone receptor antagonists are often very effective in the management of resistant hypertension because such patients often have high levels of aldosterone. The main thing to watch out for with this group of drugs is the risk of hyperkalemia, especially in patients with reduced kidney function. So it's important to periodically monitor electrolytes and kidney function in such patients. Another group of drugs that can be tried is a vasodilating beta blocker group of drugs, such as carvedilol, labetalol, bisoprolol, or nebivolol. If a patient is already on a beta blocker but it's non-vasodilating, such as atenolol or metoprolol, I typically switch that to a vasodilating beta blocker, most commonly carvedilol. Centrally acting alpha agonists can also be tried, such as clonidine. The main disadvantage of that is the lethargy or drowsiness that's poorly tolerated by the patients. And also, of course, you'll have to warn the patient about the possibility of severe rebound hypertension if he stops his clonidine abruptly after having been on it for a while. Direct-acting vasodilators can also be tried, such as hydralazine or minoxidil. The main disadvantages of these drugs are fluid retention and tachycardia. The TID dosing for hydralazine, which makes patient compliance challenging, and of course hirsutism with minoxidil. Non-pharmacologic therapy of resistant hypertension consists of diet, exercise, and moderation of alcohol intake. Weight loss in overweight or obese patients has been shown to reduce blood pressure significantly, independently of exercise and sodium restriction. A 1 millimeter decline in blood pressure is expected for every pound lost. So in my clinic, I give my patients a handout for weight loss that I wrote to help them try to lose weight. And if the patient is tech savvy, I usually recommend to them the use of the app MyFitnessPal to help them track their daily calories. Sodium restriction is also important in the management of resistant hypertension. A 2013 meta-analysis of trials involving normotensive as well as hypertensive patients found that a decrease in sodium intake of 75 MEq per day, or 1.7 grams a day, reduced the blood pressure by 5/3 millimeters among hypertensives and 2/1 millimeter among normotensives. Next, I want to spend a little time on the DASH diet. The DASH diet is a diet used in the Dietary Approaches to Stop Hypertension trial in 1997, which enrolled 459 adults with systolic blood pressure less than 160 and diastolic blood pressure less than 95. The DASH diet was high in vegetables, fruits, low-fat dairy products, whole grains, poultry, fish, and nuts. It was low in sweets, sugar-sweetened beverages, and red meats. It was rich in potassium, magnesium, calcium, protein, and fiber. Among the hypertensive adults in the study group, the DASH diet reduced blood pressure by 11.5 over 5.5 millimeters compared with those on the typical American diet, containing the same amount of sodium and the same number of calories. So in addition to the weight loss handout that I give to patients, I also give them a diagram of a healthy eating plate, which is actually a visual representation of the DASH diet. Exercise. Aerobic exercise and possibly resistance training can reduce systolic and diastolic blood pressures by 4 to 6 millimeters mercury independently of weight loss. Most studies that showed this reduction used 40 minutes of moderate aerobic exercise 3 to 4 times a week for 12 weeks. So I tell my patients to walk regularly, because walking is the simplest form of moderate aerobic activity. I tell them to walk the total of 150 minutes a week, which is the recommendation of the American Heart Association. Or if the patient engages in more vigorous aerobic activity, such as swimming or jogging, the goal would be 75 minutes a week. Moderation of alcohol intake. There's an increased incidence of hypertension among women who 2 or more alcoholic drinks a day, and in men who consume 3 or more alcoholic drinks a day. Reducing alcohol intake among excessive drinkers has been shown to significantly reduce blood pressure. In contrast, moderate alcohol intake, defined as 1 drink a day in women or 1 to 2 drinks a day in men, has little effect on the blood pressure and has been associated with a modest reduction in cardiovascular risk. So moderation is the key. In summary, resistant hypertension is defined as a blood pressure of greater than or equal to 140/90 despite the patient being on 3 medications of different classes, one of which is diuretic. There are various factors that contribute to resistant hypertension, and it's important to identify these since reversal of these factors can help improve blood pressure control. Pharmacologic therapy of resistant hypertension begins with a cornerstone 3-drug regimen consisting of an ACE or an ARB, a long-acting dihydropyridine calcium channel blocker, and a diuretic, preferably chlorthalidone or indapamide. Aldosterone receptor antagonists are often very effective as an additional agent for the management of resistant hypertension. Other groups of drugs that can be tried include vasodilating beta blockers, centrally acting antihypertensive agents such as clonidine, and direct-acting vasodilators such as hydralazine or minoxidil. Non-pharmacologic therapy of resistant hypertension consists of a heart-healthy diet and regular exercise, and moderation of alcohol intake. And that concludes my talk.
Okay, we'd like to thank Dr. Banggayan again for that very insightful lecture. But before we proceed, let us take this time to offer our gratitude towards our sponsors, MSD, Merck, Sharp, and Dome, and our media partners, the Philippine Daily Inquirer and the Filipino Doctor. So before we proceed to our question and answer portion, let's have one of our panelists give his reaction. So may I introduce our reactor, Dr. Dennis Imperio. Dr. Imperio graduated from the UP College of Medicine in 1991 and did his internship, his residency, and also his fellowship at the Department of Internal Medicine at the Johns Hopkins Hospital in Baltimore. At present, Dr. Imperio is a nephrologist at Gulf Coast Kidney Associates in Florida. So may we call on Dr. Dennis Imperio for his reaction.
I'd like to thank Lorraine for the excellent coverage of the topic. I'd just like to share some thoughts on the topic from my experience as a nephrologist in private practice for the past several years, and just like to share some pearls that have helped me as I deal with patients with hypertension, similar to what Lorraine discussed earlier. Just one thing, and I appreciate to mention that the majority of patients who have hypertension, at least in my experience, are usually not truly resistant. Most of them are either just non-compliant with medications or with their diet or lifestyle, or they may be just not inadequately, maybe just not adequately treated with medications. They're suboptimal doses or not the right combinations of medications, and see that quite often. And it's only a minority of patients that I have that are truly resistant, although they are there as well. So that's one of the thoughts I had there. The second one is I agree wholeheartedly with Lorraine about the importance of the non-pharmacological treatment of hypertension. And oftentimes we forget this aspect of treatment when we go straight to using medications. And I'm guilty of this as well. We tend to like to use pills because it's easy, and we're guilty of that all the time. And it's partly our fault as physicians, but also as from the patients where they expect us to give them medications. It's almost like it's the easy way out. And then forget the importance of using these non-pharmacological measures, which Lorraine very well discussed with diet, exercise, weight control, and things of that sort. So that's another thing that I think is very important that we sometimes underemphasize in our management of patients with hypertension that seems to be resistant. Another thing that I realize as I practice medicine in the private sector is that these secondary causes of hypertension, these so-called zebras, which are oftentimes glamorous, and oftentimes we use these for grand rounds and all that, but majority are uncommon and are the minority of cases. The pheochromocytomas, these patients that are very rare, but yet they are a cause of resistant hypertension, and yet we very seldom see them in the real world. But not to minimize the importance of these secondary causes of hypertension and resistant hypertension. They tend to be really the minority of cases. In the real world, we deal with the majority of patients who have primary hypertension that is just difficult to control for various reasons that Lorraine discussed. And then among these patients with secondary hypertension that are difficult to control, the so-called classic presentations are usually not the case. In other words, the primary hyperaldosteronism with hypertension and hypokalemia. Yes, that's one of the clues, but it's not very common to see that presentation. The triad of episodic headaches, sweating, and tachycardia, which is supposed to be the classic presentation of pheochromocytoma, in reality is not present in the majority of cases with this kind of secondary hypertension. The abdominal bruits and renovascular disease is likewise not very common as well. Having said that, just a few words about screening for secondary hypertension. I find out that, at least in private practice, if it's not going to change the management of the patient, in other words, if we're not going to do anything specifically for this patient that addresses the secondary cause of hypertension, then it's probably not worth screening for it. For instance, if a patient is not a candidate for revascularization, say with renal artery stenosis, it's really not worthwhile pursuing a test to look for a blocked artery if the patient is not going to be a candidate for a procedure. Oftentimes, we're compelled to look for things that we're not going to treat anyway. Or, for instance, if a patient's clinical outcome is not going to change, even if you have a specific diagnosis, and for instance, in renovascular disease, a large majority of patients with renovascular disease outcome will not change even if you do a revascularization versus just medical treatment. There are some instances where that's indicated, but in a large majority, it's not. And so sometimes, at least in private practice, it's not really worthwhile pursuing a diagnosis if you're not to change treatment. And the same thing goes for primary hyperaldosteronism and pheochromocytoma as well. And then just a few words on some specific treatment. As a nephrologist, we oftentimes see patients who obviously have renal failure, and there's a hesitancy or reluctance to use the ACE inhibitors or the angiotensin receptor blockers because of the concern of side effects. And that's, of course, a real concern. But my rule of thumb is that if the rise in creatinine or the drop in GFR is not more or less than 30%, then it's okay to proceed with using these drugs because of the benefit. In fact, the benefit of using that drug that reduces that intraglomerular pressure is what actually preserves renal function in the long run. And then the other ones using the mineralocorticoid receptor blockers, spironolactone and eplerenone, and Lorraine touched on this, there's the concern of hyperkalemia. Usually in our patients that we treat with these drugs, they're also on other diuretics like loop diuretics, which usually tends to control the hyperkalemia concern with these drugs. And then again, like Lorraine discussed with the use of the diuretics, I oftentimes end up having to use combinations of diuretics. You use a loop diuretic, usually with the lower GFR, but adding a thiazide to that as well enhances the effect of the drug as well. And the importance of approaching or getting to a dry weight in these patients, diuretics enhance the effect of other blood pressure medications. And then one last thing, so we can get to the question and answer session. This notion of what we call non-dippers. Normally, people with blood pressure have a normal nocturnal drop in blood pressure, which tends to be lost, especially in patients like who have chronic kidney disease or obstructive sleep apnea. And it's one of the strongest predictors of adverse cardiovascular events. And so treating patients with, say, a drug in the evening to help control the non-dipping of their blood pressure is important to help control that aspect of their management. Now, I'll leave it at that. I didn't want to go into too much detail about some of these other secondary causes of hypertension, and maybe just move on to the question and answer session where we can address specific issues as they come up. But I thought I'd just leave these pearls that might help with some of these management issues of resistant hypertension.
Thank you, Dr. Imperio, for your reaction. I want to encourage all our listeners to send over your questions. We do have a number of questions for them. And first question, I guess, is directed towards Dr. Lorraine.
Yes.
The question comes from Rodolfo Selli, and he wants to know well, maybe very interesting that we want to know how many ml of wine is per drink. What kind of liquor are you referring to? So the question is, kindly clarify further about how many ml of wine is per drink.
All right, so
liquor.
One drink is 12 ounces of beer or 1.5 ounces of hard liquor like vodka. Wine. So what did I say? 5 ounces for wine. 5 ounces of wine, 12 ounces of beer, 1.5 ounce hard liquor is one drink.
All right. Thank you very much. Another question from Rodolfo Celis. If there is a need to give pain reliever, so apart from a non-steroidal anti-inflammatory agent, what other alternative is there apart from paracetamol?
Apart from paracetamol, well, and if they can't have non-steroidals and other non-pharmacologic ways of controlling the pain, there are certain. So depending on what, so there are some options. Like depending on what part of the body is hurting, like lidocaine patches or tramadol, or see the good thing about being a cardiologist is you can also say, talk to your primary care doctor more about the pain control. but typically trying to figure out what are the other ways that could control the pain. Like so sometimes, like for example, leg cramps at night, stretching exercises, physical therapy, non-pharmacologic methods. And then, yeah, capsaicin cream over the area that's hurting, or lidocaine patch, or tramadol, if paracetamol doesn't work.
Can we have another reaction from Dr. Imperio regarding this question?
Well, I agree with Lorraine. One of the benefits of being a specialist is we punt it over to the primary care physician. But I think the concern was more because of using particular drugs that would raise blood pressure. Personally, I from a renal standpoint, if it was just a short-term use of, say, a non-steroidal anti-inflammatory drug for a short period of time, even if they have renal failure, I usually have no problem with that if it's a limited period of time. So for acute pain and they just need some pain relief for a few days, you weigh the benefit of using a drug that might have some side effects that for the short term may not be so significant. So yeah, I sometimes allow them to use drugs that we normally would have allowed them to use if it was long term.
Yeah,
the non-steroidal anti-inflammatory drugs would use it.
I agree. For acute pain, for short-term use, non-steroidals are okay. But more than 2 weeks, probably you have to think of something else.
Right.
Right. Thank you very much. We have another question. This time from Dr. Catherine Haynes. Right. So, Dr. Lorraine, if you see a patient for the first time and he or she is not a diagnosed case of hypertension yet, but at presentation, their BP is 190 over 120, remains asymptomatic, no other known comorbidities. He has other complaints, for example, maybe an animal bite upon consult, but the BP is quite elevated. How will you approach this kind of patient? Will you give medications right away for hypertension to control it? Or what is the drug of choice you use?
That's getting into 190 over 120. The 120 is already getting into the range of hypertensive urgency. First, that I would have the patient rest for, recheck the blood pressure after 30 minutes. And if it's still very elevated, if you're able to in clinic, so see, the main thing is to make sure that, and you're saying the patient is asymptomatic. So the main thing is to be able to safely lower the blood pressure over a span of a few hours. And this can be done if I've done it sometimes using clonidine in my clinic, but to make sure that the patient has to be monitored, the blood pressure has to be checked frequently and not just prescribe clonidine. And that's for acute lowering. So you give clonidine 0.1, and then after an hour, see what the blood pressure does. And you just want to see it gradually come down over a span of a few hours. And of course, you have to then figure out a regimen, a more regular regimen for the patient. I wouldn't put use the clonidine as a regular blood pressure agent for him to use. Then once the blood pressure is at a more reasonable level, then use the other drugs that we have discussed, like an ACE or an ARB or a calcium channel blocker and a diuretic. So, but acute, so 190 over 120, the acute concern is you want to start lowering it gradually over a few hours, and then once it gets to a safer level, you decide on a regimen to send the patient home with that he would take regularly.
Thank you. In relation to this question, Dr. Haynes wants to also know if clonidine is not available, can she give captopril instead?
Yes, that's also an option.
All right, thank you very much. The next question comes also from Dr. Catherine Haynes. I heard from previous lectures that we should not be giving sublingual medications for hypertensive patients. Could you please comment on this?
Sublingual medications, haven't used it in decades. Yeah, it's not safe. It drops the blood pressure too abruptly. So I agree. I don't use sublingual medications like sublingual nifedipine that was so in vogue many years ago. That's a no-no now.
Thank you. We have Dr. Ray Sanyal right here at the studio. He wants to know, he has been encountering a patient with really high blood pressure. The patient is very young, 25-year-old male, and just this morning he presented in his clinic with a BP of 180 over 110. He remains asymptomatic, was given catopres sublingual. But what should be the anti-hypertensive approach regarding pharmacologic therapy and probably diagnosis of maybe secondary hypertension causes?
180 over 110 on no medications?
Just given catopres sublingual.
No, I mean prior to catopres, no medication.
None.
All right. 180 over 110, I mean, it's not necessarily a panic value. Basically, I would just decide on starting the patient on at least two different medications to begin. So maybe either an ACE and a diuretic, or a calcium channel blocker and a diuretic, or an ACE, any combination of the ACE or an ARB, the amlodipine, or a diuretic. So start on either, maybe at least two of these three drugs, two of these three drug classes.
Dr. Banggayan, the patient is a 25-year-old male. Should there be any further workup for this patient, considering the fact that he's quite pregnant?
Well, yeah, workup will definitely include checking the electrolytes and taking a very thorough history, like are there any symptoms that could be suggestive of, I don't know, or pheochromocytoma or things like that. So, and also the family history. Does it come from a family history of people with essential hypertension? So taking a thorough history, getting basic labs, particularly the electrolytes and kidney function, thyroid function. So those to begin with. Those to begin with, and if after that, on the next visit, if any of these turn up anything suspicious, like a potassium that's unusually low, or thyroid is abnormal, then you go from there. But I don't necessarily go looking for secondary causes. Secondary hypertension, if it depends on the patient, like what the history is like. I mean, it's a possibility, secondary hypertension, but you really won't be able to suspect that until you have more information.
Thank you very much, Lorraine. Dr. Imperio, regarding this same patient, would a consideration of renal artery stenosis be quite a possibility?
This is a male, right?
Yes, he is.
Yeah. Well, there's two general classes of patients who we worried about with vascular disease, and the majority are those who are older and at risk for atherosclerosis. So they're the older patients, hypertensive, diabetic, heart disease, peripheral vascular disease, and they have atherosclerotic renal disease. He probably doesn't fit that profile because of his age. And there's the other group that has fibromuscular dysplasia. Typically, they're young females. So it doesn't fit that necessarily. So I wouldn't necessarily look for that as the primary reason for his having hypertension. He does seem a little bit young to have hypertension, although we are seeing that a lot more recently in the patient. But renal artery stenosis would not be up there, but we would still want to screen that if there's any risk factors or any concerns that might be playing a role. He doesn't fit the profile, though.
Thank you. We have another question from Eric Asuncion. If a patient comes to you, he has normal blood pressure, 90/60, but with a BP of just 110/90, he complains of severe headache and vomiting. Can a antihypertensive be already given to this patient?
I'm sorry. Could you repeat the question?
All right. The question is, someone with normal blood pressure.
Normal blood pressure, yeah.
Yes, 90/60, but complains of headaches and vomiting. When you take his BP, it's only 110/90. Is an antihypertensive warranted on this case?
No, 110/90.
Correct.
No. I mean, the blood pressure, if the patient is not feeling well and it's vomiting, and it's normal for the blood pressure to go up a little bit, and 110/90 is not hypertension, really.
That's right. All right, thank you. Another question from Dr. Catherine Haynes, and maybe a follow-up to her previous question. What are the contraindications to captopril?
Angioedema, mainly angioedema and other side effects like like if the patient has not been on captopril before, like which patients you would not put the patient on captopril. a patient who has hyperkalemia, for example. And then, as Dr. Imperio mentioned, renal insufficiency is not necessarily a contraindication. If there is an acute rise in creatinine recently, then I would not do captopril. If there was an acute rise in creatinine recently. But so basically potassium level and recent acute rise in creatinine, I wouldn't do captopril.
All right, thank you, Dr. Banggayan, for engaging, very engaged discussion. And we would like to thank also Dr. Imperio for all his reactions as well. To summarize, we learned that, of course, resistant hypertension needs to be attended by someone who is knowledgeable in the treatment of hypertension. It may be silent. There are a lot of contributing factors. Patient compliance probably being the most important factor mentioned. There are many drugs available for treatment of hypertension, but it must be stressed that if you do have hypertension, go see your cardiologist. It's very important that you are under close monitoring and observation by your clinical physician. Of course, non-pharmacologic approaches as well have been mentioned, diet being one, and exercise, and of course, moderation of alcoholic intake. So we'd like to thank Dr. Banggayan for such an engaging discussion on resistant hypertension. And of course, after this session, I'd like to remind everyone listening, an email containing a survey link will be sent to you. And after answering the survey, your certificates will be sent to you. Please answer the survey so we can assess our webinar and address more of your preferences and give you materials from this session as well. Thank you again for joining us. We hope to see you again in our upcoming webinar dated September 7th. So mark your calendars. That's Wednesday, September 7th, 12 noon Manila time, with speaker Dr. Reynold Ramiro, and his topic will be pins and needles of neuropathic pain. So please invite your colleagues to join this continuing monthly CME webinar series. All webinars, all webinar schedules and resources will be posted at let me say that again, www.upm.edu.ph/UP-webinars. On behalf of UPCM Class 1991 and the UP Medical Alumni Society, we also thank our collaborator units, the UP Manila Information Management Service, thank you, John. National Telehealth Center, the UP College of Medicine Postgraduate Institute of Medicine and Medical Informatics Unit, the DOST, ASTI, and Ms. Charisse Orhalio for being our gracious hosts. We would like to thank also all our sponsors and partners, MSD, Merck, Sharp, and Dome, our media partners, Philippine Daily Inquirer, and the Filipino Doctor for their support as our media partners. So this is Randy Nicholas, together with Lorraine Banggayan and Dennis Imperio, and the entire UP webinar team closing this session. Thank you for your attention, and we hope to see you again on September 7th. We hope you have learned a lot from today's webinar. Thank you again.